Hello everyone and welcome to our second session on secondary stroke prevention. In the previous webinar, we focused on identifying modifiable risk factors after stroke. Today, we're going to take the next step. So we're going to be moving from what to target on how to actually reduce the risk in a meaningful and sustained way. I'm delighted to be joined by an outstanding panel of experts, Drs. Hanne Christensen, Joseph Kwan, and Jesse Dawson. Could I ask each one of you to briefly introduce yourself and just describe your main clinical or research focus in stroke care? Hanne?
Yes, thank you very much, Aristeidis. I'm a vascular neurologist and I work as professor of neurology with the University of Copenhagen, and I work clinically as stroke consultant at Bispebjerg Hospital in Copenhagen. And my interests are a bit too broad because it's basically clinical stroke research and implementation.
My name is Joe Kwan. I work as a stroke physician at Charing Hospital in London. My background is in general internal medicine and gerontology. My academic work is done at Imperial College London, and I'm a senior lecturer there. I have quite a diverse academic research portfolio, including acute stroke treatment and post-stroke complications. In the last decade or so, I've veered into lifestyle medicine and lipid lowering, so my current focus is now stroke prevention, especially with lifestyle changes and lipid lowering. Thank you.
I'm Jesse Dawson. I'm a professor of stroke medicine at the University of Glasgow in Scotland and work clinically as a stroke consultant in NHS Greater Glasgow and Clyde. And my background is a little different. I'm not actually a neurologist by training, although I trained as a stroke specialist. My background was really in clinical pharmacology and in cardiovascular risk factor management. So one of the key areas of interest I had as a trainee and as an early consultant was actually in blood pressure, and ran a large hypertension clinic in the west of Scotland. So very motivated to try and improve the way that we can prevent second strokes and recurrent strokes.
Thank you so much for all being here and sharing your expertise. I'm so glad to hear all this diversity in expertise. We're going to have a wonderful discussion. So let's get started with the medical interventions that we actually use in our everyday clinical practice. We have stroke evidence supporting a wide range of pharmacological therapies for stroke prevention. One of the most important pillars is anti-thrombotic treatment. So we have antiplatelets, anticoagulants, and let's start with that, Hanne. So can you give us an overview of the blood thinners we're using for stroke prevention?
Certainly, thank you. I think when you have a stroke patient and you need to decide how to continue with the antithrombotics, then the first thing you need to figure out is whether this is a cardioembolic or a non-cardioembolic stroke. Of course, you may not know that it's cardioembolic before having the Holter results, but so you must go by what you know at the time, whether it's cardioembolic or not cardioembolic. If it is cardioembolic, then it's mainly about atrial fibrillation, but there's also a number of high-risk structural cardiac conditions that could lead to cardioembolic stroke, including moral thrombosis, mechanical waves, valves, etc. But the vast majority of these patients will have atrial fibrillation. For anticoagulants, we have the DOACs, the direct oral anticoagulants, and there are 3 factor 10A inhibitors and 1 direct thrombin inhibitor. And overall, I would say that they're all excellent drugs, very comparable as to benefits and harms. They have the advantage of fixed dosing. And for the majority of patients, the selection of the actual drug can be made based on price and number of daily doses. And the dosing should be done as recommended by the manufacturer and will depend on things like age, weight, kidney function, but always look it up because there are 4 of them and nobody can remember everything. So when can you start the OACs after an ischemic stroke? You can start it within 48 hours after a minor or moderate stroke, or on day 6 or 7 after a major stroke. And you must be aware that in the older days, we initiated the OAC pretty much later, but based on newer data, there is probably, or there is, based on the Eland study at least, a slight advantage as to the reduction of early events by initiating as early as that. There's also warfarin, which has been used for many, many years. And I think that it's important that we are aware that if the patient is kept at 70% of the time in therapeutic interval, then it is actually rather comparable as to both benefits and harms as to DOACs. And that can be achieved through self-monitored VKA. But overall, this is extremely difficult, cumbersome, and takes a lot of resources to achieve, why most clinicians prefer using DOACs. And also because of all these blood tests, because of course the dosing is based on the IRNR. But there are specific conditions like mechanical valves and antiphospholipid syndrome that must have VKA. If we go to the non-cardioembolic stroke, which for most patients will mean that simply they don't have AFib, you have to look at short-term versus and long-term, because these are two different issues. And I'm following very closely the ESO guidelines in what I'm saying, and not just all guidelines. And I just want to recognize that Jesse Dawson was actually first author of both of these ESO guidelines. And as to the short term, where we're talking about dual antiplatelet treatments, this is really about the balance of benefits and harms. That is, that dual antiplatelets will inevitably reduce the risk of a thrombus, but it will also increase the risk of a bleeding. Wherefore, the question is to reach the sweet spot of timing and stroke severity. So the recommendations based on trials, but pathophysiologically, I think we can say that this is really based on the timing, reaching the sweet spot between thrombosis and bleeding, with the reduced risk, with the risk going down in the days, weeks after the event. We end up at having a recommendation, which is strong from ESO, that in minor stroke, which is very minor, NIH below or at 3, or high-risk TIA, dual antiplatelets with ACE and clopidogrel for 21 days is recommended if initiated within 24 hours of onset. There's also a less strong recommendation for ticagrelor and ACE to be used in mild to moderate stroke, that is going up to 5 in an NIH, and high-risk TIA for 30 days, but it must also be initiated within 24 hours. I think that clopidogrel and ACE, the clopidogrel and ACE option is what is really mostly used. And then long-term will be from 21 days and onwards. And that is monotherapy, antiplatelet monotherapy. In the ESO recommendation, we do not say that this should be aspirin or this should be clopidogrel. It is a monotherapy of antiplatelet therapy that is recommended. And this is a strong recommendation. I just also want to mention that there's also the option of aspirin plus dipyridamole. This is, of course, 2 drugs, but dipyridamole in itself does not increase the bleeding risk, and it's well tested. This is also an option for some patients. It's more cumbersome, it's more expensive in most countries, but it is certainly an option. And ESO also recommends directly against long-term use of dual antiplatelets due to the risk of harms. But longer-term treatment can be relevant in severe intracranial atherosclerosis as the main issue. There's also the option in specific patients, after specific consideration, who have generalized atherosclerotic conditions, including peripheral atherosclerosis, also ischemic heart disease, and prior stroke and lesions in the carotids. We mainly use it in the patients that keep having strokes. to use ASA and low dose rivaroxaban based on the COMPASS trial. So these are basically the recommendations and the options. So what to do: make the first workup of patients, find out is it cardioembolic or non-cardioembolic. Ensure that in the mild strokes, minor strokes and high-risk tears that you can actually start the treatment within 24 hours so that the patient gets the option of having dual antiplatelet treatment. And then ensure that the ASA is stopped after 21 days, at least in Denmark. Continuing aspirin for too long is one of the most common pharmacological accidents that happen, and this does actually and significantly increase bleeding risk if stopping is forgotten. And often patients may feel that if this is good, it's good to continue. So a lot of attention on that. We actually hand out tablets for 3 weeks to avoid this issue, and then ensure that patients are well aware that they should continue the monotherapy of antiplatelets lifelong.
Thank you so much, Hanne, for presenting this wealth of evidence, summarizing very nicely into an algorithmic approach and also sharing your clinical experience. So we're going to move from the antithrombotics to another pillar, which is dyslipidemia management. So Joe, I'm coming to you, and I would like to ask you, what are the agents that we use and which targets should we aim for? And Hanne mentioned a lot about, stroke subtyping, presumed etiology, and timing of starting antithrombotics. Is it something that we take into account when we start, agents to reduce the LDL or triglycerides? What are your thoughts on that?
Yeah, thanks so much. It's a great question. It's taken quite a few years for LDL to be established as a major risk factor for ischemic stroke. Unlike acute MI or ischemic heart disease, their relationship is very, very solid, even 4 or 5 decades ago. But, research in the last couple of decades have really consolidated the place of LDL lowering in prevention of acute ischemic stroke. So, for example, we have the SPARKLE study that using atorvastatin at 80 milligram for patients who've had a stroke, the number needs to treat to prevent one stroke or TIA was only 11. And the number needed to treat to prevent one major adverse cardiovascular event was only 5. So when you use statins, high dose, high intensity statins to treat a stroke patient, you're not only reducing the risk of another stroke, you're reducing the risk of ischemic heart disease, peripheral artery disease, aortic aneurysms, etc. So it is a very, very worthwhile treatment. For every millimole reduction in LDL, it equates to 20% relative risk reduction in stroke risk. So it is now a very important part of the armor of stroke prevention strategy. In terms of targets, that's a really good question. It's really interesting how different countries have different targets. So if we follow, the first one I want to talk about is the European Atherosclerotic Society, or the European Society for Cardiology, the ESC guidance, because that is the one that most European countries follow. And that they had an update in 2025, and they tend to go harder. They go quicker and harder with the statin and lipid lowering targets. So even with one event, and it doesn't matter whether it's cardiac event or a or cerebral vascular event, their target is already down to 1.4, even just with one event. With polyvascular events, so for example, someone who's had a TIA or stroke and ischemic heart disease, or acute coronary syndrome, with two things together, they go straight for a target of 1, LDL target of 1 or below. So when you have a recurrent event, again, the target is below 1. So they go hard and strong. In the UK, we're slightly different. So our national clinical guideline, the target is 1.8, which is the target they used for the treat to target trial. But in the NICE, which is the National Institute of Clinical Excellence that we have in the UK, they take into account the cost effectiveness, and they have an LDL target of 2 or below. So we have this kind of slight discrepancy between guidelines and between countries. But the question is it safe to go well below that and towards 1, which is quite often found nowadays? And it's really nice to see data coming out recently to show that LDL of 1 or below is not only safe, but also had clinical benefits. So the general approach to lipid lowering after a stroke is strike early, strike hard. The first line that we use and most people use is high-dose statin. So some people use atorvastatin, for example, in the UK as first line. Some people use rosuvastatin as the first line. And then we start adding other ones. The oral agents to add are ezetimibe and bempedoic acid. They're the 2 main oral agents. There are combined tablets of ezetimibe and bempedoic acid. In the UK, that is called Nustendi. That is an approved treatment. We also have the injectables, and they are the PCSK9 target injectables. One is the monoclonal antibodies, and there are 2 on the market. One is called evolocumab, one is called alirocumab. The other one is the small interfering RNA, and that is called inclisiran. And they differ mainly in the frequency of injections. So, for example, inclisiran is twice a year, whereas the MABs are usually once a month. So the combination, if you use the EAS guideline, which combination you use depend on your baseline LDL at the time of the event and how much you want to reduce your LDL by. So as a rule of thumb, if you use high-intensity statins, such as atorvastatin, 80 milligram, you're expecting about 50% LDL reduction. If you add every oral agent you add, the rule of thumb is you add another 10% reduction. So it goes 50%, 60, and then 70% if you have all 3 oral agents. The injectables are more potent. Each one reduces by about 50%. If you add it onto a statin and the oral agents, you can reach above 75 or even 80% reduction from baseline. So that is how we target which oral and injectable agents to use, depending on how much you want to reduce it by. Triglyceride, you mentioned, it's another emerging, really important risk factor. How do we know someone has high triglyceride or not? That is determined by a fasting triglyceride of 1.7 or a non-fasting triglyceride of above 2. That is what we mean by a high triglyceride. Interestingly enough, triglyceride is mainly from a high-fat diet or insulin resistance as part of a metabolic syndrome. So the first line of treatment is to change their lifestyle and diet. And then afterwards, if they're still high, there are medications such as the fibrates, such as fenofibrates, but also there's a new medication called icosapent ethyl. And that is a highly purified form of omega-3 EPA. But importantly, only icosapent trial has been shown to reduce MACE outcomes. Coming to the last thing, which is to do with stroke etiology. Although LDL is a predictor for all stroke subtypes, including the cardioembolic strokes, but all the trials show that the statin-based treatments are only effective for those strokes caused by atherosclerotic disease. If you have a stroke caused by dissection and some genetic disorder, statin has no proven benefit in those patients. And there is no, then if they have a high LDL at that point, that is regarded as a primary prevention. We use scores like QRISK-3 or SCORE-2 in Europe to predict whether we use a statin or not. So that's a summary of the lipid lowering aspects.
Thank you so much, Joe, for this absolutely stunning and great overview. So now let's talk about blood pressure management. So I did hear that Joe mentioned that when you're dealing with lipids, you strike early, you strike hard. Is it the approach that we should be taking in the management of hypertension, Jesse? What is your approach in treating high blood pressure?
Yeah, thank you very much. So I think we need to tease out some of the issues around acute management of blood pressure in the context of acute endovascular therapy and thrombolytic therapy, for example, and prevention of stroke thereafter. And I'm not going to focus on the acute treatments, but really just deal with when we think about starting preventative treatments for blood pressure and why. And although it's certainly nice to hear about the changes in lipid management. The blood pressure field has been less dynamic, I think, before, but that doesn't, in recent years, but that doesn't mean it doesn't remain probably the most important risk factor for stroke in terms of population attributable risk. And we know that blood pressure level has a log linear relationship with risk of stroke. So a 20/10 increase in blood pressure is associated with a doubling of the risk of stroke. And that's also the case for risk of recurrence. So it's a hugely, hugely important risk factor. And we know that lowering the blood pressure works. When we performed the meta-analysis for the EASO secondary prevention guideline of blood pressure reduction, there was roughly a 20% reduction in the odds in the risk of recurrent stroke in people with ischemic stroke when blood pressure was lowered. So at the most simple level, we know that lowering the blood pressure is a hugely effective treatment. And we also know that the benefit is greater in intracerebral hemorrhage in terms of the risk reduction that it affords. So the obvious question is, should we use blood pressure lowering drugs? Of course we should. There becomes a much more difficult question, important question around the targets that we should aim for. And this has in the past been complex, where there were different targets for stroke, for myocardial infarction, for CKD, for diabetes, for example. But there has been a general coalescence around a more intensive approach toward blood pressure reduction. And indeed, if you look at the stroke-specific data, you see that across 3 studies that we looked at when we did the secondary prevention guideline, SPS3, PASS-BP, and the RESPECT study, comparing a more aggressive approach, aiming for a blood pressure of less than 130/80, was associated with a significant reduction in the risk of recurrent vascular events compared to a target of 140/90. So intensive control in people with stroke is better. And again, that risk was particularly, or that benefit rather, was particularly great in people with intracerebral hemorrhage, where with regard to hemorrhage as an outcome, where the risk of a hemorrhage was almost halved, and that was in people with an ischemic stroke. So it's a hugely effective approach to lower the blood pressure, and generally speaking, we should be aggressive, aiming for a target of 130/80. So I think that's our starting point when we think about blood pressure, is aim for a target of 130/80 unless there is a specific reason not to. And it is important to note that there are concerns in some groups of patients about more intensive blood pressure reduction. And I think the obvious one to highlight would be carotid disease. If you look at data from the endarterectomy studies, such as NACIT and ECST, there does appear to be a relationship between a higher stroke risk and a lower blood pressure in those with bilateral severe disease, but that's a small group of patients that we see. And I think perhaps the more clinically important nuance that we have to consider is age. As we'll all know, the average age of patients in a clinical trial is far less than the average age of the patients that we treat, and they tend to be much cleaner populations in terms of frailty and comorbidities. And it's certainly true that we do not have good data on how low we should go with blood pressure in a frail population. And again, some studies have shown that intensive treatment can be associated with adverse outcomes in people who are extremely frail. So we do need to have that nuance in our mind. And also we know that the treatment effect of lowering the blood pressure in an older, frail person is less in terms of the number needed to treat for important outcomes such as mortality because of those competing risks of other outcomes. And another subpopulation of interest is people with renal disease. And we think about that, I think, for two reasons. One is many of our people with stroke that we manage will have renal disease, and lowering the blood pressure is important to reduce the risk of renal disease progression and other cardiovascular outcomes. But we did see in sub-analysis of the SPS-3 trial and also in post-hoc analysis of the SPRINT trial that intensive blood pressure reduction has been associated with a reduction in eGFR and some adverse renal events, but that was greatly outweighed by cardiovascular and all-cause mortality benefits. So again, just to summarize that so far, obviously we should lower the blood pressure. In principle, we should be more aggressive. We should be aiming for 130/80 millimeters of mercury as our starting point, and then taking a step back and saying, are there any high risk features that would make that blood pressure target inappropriate for this patient, such as bilateral carotid disease, such as advanced frailty, advanced age, and risk of renal complications. And then the more difficult questions, and where I think it does get a bit more fun, is, well, how do I do it, and what do I use? My approach is certainly just to follow the British Hypertension Society and the NICE UK guidance for blood pressure lowering, because it has a very simple framework of ABC and then fourth line treatments. So you start with either an ACE inhibitor or an angiotensin receptor blocker, or a calcium channel blocker, or a thiazide diuretic. More appropriate for stroke patients to consider thiazides as a first line treatment, dependent on age, dependent on other factors such as comorbidities. So we start on one of those drugs, dependent on which is most suitable, and guidance often suggests to use a thiazide or calcium channel blocker in older patients above the age of 55, or ACE inhibitors in lower patients where they may have a high renin state underpinning their hypertension. And then if you need a second drug, you pick one from the opposite side. So you would add in an ACE inhibitor to the thiazide, or you'd add a thiazide into the ACE inhibitor. And if you need to move to third line therapy, you could use those three groups together: an ACE inhibitor or an angiotensin receptor blocker alongside a calcium channel blocker and a thiazide. And then we have fourth line agents, and the choices of that, it becomes more complex, but options might be things like spironolactone, alpha blockers or beta blockers, depending on what the potassium levels are, for example, and depending on whether there are other comorbidities. So that's quite a nice, simple framework to follow. But one of the questions that I think is of more contemporary interest is, should you start with just one drug, or should you start with two drugs? And again, there's rationale for starting with two drugs as opposed to one. One is there's some evidence that two low doses of one medication is as efficacious and associated with fewer side effects, and it is easier, generally to use in terms of not having to have multiple dose titration steps for a single therapy. There's no definitive evidence that using two drugs is better than one in terms of outcomes, but it was interesting to see just a few weeks ago at ESOC, and this is in the intracerebral hemorrhage space, the results of Trident that showed that using a polypill of three drugs in patients with intracerebral hemorrhage was associated with a significant reduction in events thereafter. So I think using multiple therapies early after stroke will become an increasing question of interest, and certainly that I'm beginning personally to move in that direction. Particularly, for example, if somebody's blood pressure is 172 over 90. starting an ACE inhibitor at a dose of ramipril 2.5 BD or perindopril 4 milligrams is not going to achieve the required reduction to get that patient down to 130/80 in all probability. So perhaps starting them on a dose of amlodipine at 5 milligrams and a dose of an ACE inhibitor, a starting dose of that, will be more efficacious and make it easier for the GP to take on subsequent dose titrations by just doubling up the perindopril, doubling up the amlodipine. You might actually make the whole landscape a lot easier for the future management of the patient. But I'd be very interested to hear what agents other people use, because I don't think this is an evidence-based area which agents we select after stroke, with the exception of the PROGRESS trial, obviously showed us that using perindopril and indapamide in combination was highly efficacious. But which one you pick first and whether these are just class effects is an area of debate, I think.
Indeed, Jesse, I would also like to hear what other people are doing. I'll have to confess that I'm still doing the old school approach, starting one agent and going up slowly. And the reason I'm doing that is because that's how I was trained, right? So, but I would like to hear, Joe and Hanne, what is your practice regarding agents? And if you're starting with a combination or a single blood pressure regime. So, Joe, do you want to share your practice?
Yeah, it's very personalized, isn't it? It's as you say, it depends on so many things. So if they already have swollen ankles and they're they have postural blood pressure drop, then that might determine which agents you use. I mean, thanks, Jesse. I mean, that's a really nice summary. And in my head, I was thinking, what about this group? What about this group? Older people with significant postural hypotension, recurrent falls, people with diabetic renal disease, who need, renal protection, for example. So, I mean, I tend to start with a calcium channel blocker first if it's rather mild. Like Jesse, I'm starting to do two agents, quite often combining an ACE inhibition with a calcium antagonist, or a thiazide with a calcium antagonist. So, it's definitely a moving field. In the UK, we don't tend to have many combined tablets, whereas in the US and maybe in Europe, they have more kind of combined agents, which patients find it easier to take, don't they?
Thank you so much, Joe. And Hanne, what is the experience?
Well, actually, we're doing pretty much as Jesse said, and it's also because we have also a close collaboration with the GPs, so we see them once, perhaps twice, and then they are returned to the GPs for blood pressure control, and usually it's. That's the way we go because it's fast, efficient, and patients do not complain too much.